experience of introducing telehealth and telecare in the UK, which has been very interesting over the last 10 years or so, because it includes the world's largest randomized controlled trial of telehealth. So you can all hear me, can you? Yes? Okay.
Yeah.
Right. So let me just get started then in that case.
Okay.
So what, can you see me? I'm just not sure what you can see as well. Or do you just see the slides? Are you just seeing the slides, or do you see me as well?
No, Professor. Yeah, they can see you. They can see you. They can hear you. Or they can see the slides. Okay.
Okay. Dear Professor, all is okay.
All right. Well,
yeah, all's good.
Good. Well, let's get started then, shall we? Well, what I want to do really is to, first of all, talk a bit about what we mean by remote care, and I'll define that in a moment. And then I'm going to explore the history of its adoption in the UK, and talk a little bit about the whole system demonstrated program. And then we're going to look at some of the lessons. And I should say that I've been a professor at Imperial College for about 13 years now, and a lot of my work has been around the introduction of innovation into healthcare, and a lot of that work has been about telehealth and telemedicine. So I have a lot of experience looking at this problem of remote care. Before I move on, I mean, can I just ask you, what do you know about telehealth and telemedicine? How much have you looked at this in your course? So somebody can send me a message. Have you studied this in the course so far, or?
Not just yet. Not into too much detail. We've just done pretty much a lot of the basic stuff and getting introduced to it, and we've done some stuff on EHR and EMR. Okay. Nothing about the remote care itself.
All right, good. Well, I've also, on the next slide, there's a lot of reading there. I don't expect you to do all that. I've indicated the important ones with an asterisk. But those are some of the papers that came out of the big randomized controlled trial that I was involved in, and a few other papers as well. So that will give you a bit more depth to what I'm going to talk about in the next 45 minutes or so. So what do we mean by remote care? Well, I mean, it goes back a long time, and I suppose when I first started looking at this, a lot of the discussion was around smart homes, intelligent homes. And this was about homes designed to be connected. So all the different functions in the home were connected through information technology. And they were aimed very much at disabled people and elderly people. So going back about 15 years or so, we had a lot of interest in assisted living. And by that I mean using technologies to support people who had reduced functionality. They were disabled. There's a lot of noise in the background. I'm not sure what that is, but it's making it a little hard to concentrate. So perhaps if you can keep the noise down. I don't know where that is. So there were, going back to the sort of early 1990s, mid 1990s, there was a lot of efforts to try and develop new technologies for assisted living. And by that I mean technologies to support people who are disabled, people who are elderly and frail, people who perhaps were at risk of falling because they had reduced mobility. And in the UK, United Kingdom, we had a very sophisticated or widely developed community alarm system where elderly people were given devices in the home to trigger an alarm if they'd fallen, and then an alert would be sent to a monitoring center, and then a response would be provided. So this goes back 20 or 30 years now, well, in fact, a bit longer than that. So we already had the basic infrastructure for telehealth and telecare established in the UK, going back to the 1980s and 1990s. And around that time, around the mid-1990s, there was a lot of talk about combining all these different technologies into one fully integrated smart home, bringing together all those different disparate technologies and integrating them around the home itself. Are you still with me? Okay. If anybody's got any questions, please use the chat system just to ask a question. So that's going back about 20 years or so, and the terminology is quite difficult here because people tend to use a lot of different words which tend to mean the same thing. We talk about telecare, we talk about telehealth, telemonitoring, telemedicine, assistive technology, smart homes, and all those terms are basically used to mean the same thing. They're all used fairly interchangeably to deliver, to describe the way we deliver health and social care remotely. And by that I mean we deliver health and social care into people's homes or people on the move out in the community using information technology. And that's what I mean by remote care. So many different terms are used to mean the same thing. Telemedicine itself is, for me, and different people use these terms in different ways, but telemedicine for me is very much about healthcare professionals being connected at distance so that you can, you know, a healthcare professional in one location can talk to another one and get a second opinion, for example. So you might find, you know, nurses in a remote rural area with a patient talking by a video link and perhaps sending some data to a doctor or specialist in a hospital. That's what I mean by telemedicine, which I think is something rather different from telehealth and telecare, which is much more complex. And the next slide will show why that's the case. Because when we're talking about remote care, we're talking about several different applications being delivered remotely to an individual in their own home or wider environment. Some of those applications are about the home itself, monitoring the home itself, and that's at the top there. So that's making sure that, for example, an elderly person with dementia hasn't, you know, left the stove on, hasn't left the bath overflowing. You know, there isn't gas from an unlit cooker in the flat. So some of those applications are about safety and security in the home. Some of them are about the individual themselves, and that can be monitoring the individual's vital signs, physiological signs, or it can be about monitoring their lifestyle and activities of daily living. So by that I mean looking at whether they're active, whether they're moving around, have they perhaps not got out of the chair for 24 hours, have they been to the fridge to get some food. So it's looking very much at activities of daily living. And then some of it is around just connecting people up, providing advice, support, self-care, connecting up groups of people, perhaps all with Parkinson's disease, through some sort of internet-enabled support network. on the left of that diagram. And then, of course, there's all the original technologies that I talked about just now about assisted living. So devices to control the operation of doors and heating and lighting and ventilation in the home. So all that is about remote care. It all forms the bundle of applications that we call remote care. And telehealth is remote care that is focused very much around health applications. So prevention of the onset of disease or the exacerbation of a disease. And some of it is about mitigating risk. So frail elderly people at risk of living on their own in a home, which is much more about telecare. So are you with me? So there's lots of different applications which all come under the bundle or the term remote care. And some of it is focused more on health, and some of it's focused more on social care. And some of it is about mitigating risk, and some of it's about prevention of a disease becoming exacerbated, because you're monitoring that disease more carefully and intervening in an earlier way. Okay? All clear? Okay. Yeah?
Yeah.
Good.
Yeah.
All right. Well, I'll move on in that case. And the key components of any remote care system are these, really. First of all, they're a bundle of different monitoring devices. Some of those are worn on the body. Some of those are embedded in the home itself. But they're monitoring vital signs. They're monitoring people's activity, people's movement. They're monitoring the home itself and temperature and carbon dioxide and so on. And they're all connected up, perhaps through some kind of home hub in the middle. And the data from those different devices are either sent to the individual, so you can look at your own data and look at how that's evolving and changing over time, which can be very useful because it gives you an indication of, what your general level of activity or health. Or it gets sent to some sort of monitoring center. And then the monitoring center is looking at exceptions, basically. Has that data gone outside certain parameters for that particular person? Have they, we know that they spend every morning sitting on their favorite chair for 2 hours, but if they haven't got out of that chair, then an alert is triggered, and then some sort of response is given. So the response could be simply phoning that person up initially, but then if they don't get a reply, then maybe you call the neighbor goes around to visit them. Or, if it's a real emergency, then you call an ambulance. Or you might just phone the person and say, your blood pressure is slightly high. Please, could you make an appointment to see your doctor? And so it's really all about looking at that person's changing condition, whether it's looking at their vital signs or their activity, and trying to build up an understanding of what is normal activity, normal behavior, normal parameters for that person, and then only intervening if you go outside those parameters. And the reason for that is that doctors don't want to be flooded with data on lots and lots of individuals. They simply need to know that that person is fine until there's the beginnings of a problem being detected by the system. So you can see that as a concept, remote care is much more complex than simple telemedicine. Simple telemedicine is basically just about connecting up healthcare professionals, possibly with the patient present, but healthcare professionals who are distantly located, and looking at that patient and looking at the data and coming to a collective decision about what to do about that patient. So it's a much simpler technology to introduce than remote care, to telehealth, telecare, where in real time you're monitoring people in their homes or on the move, and you're intervening if appropriate. Now I've got a question just come through which says who supports the device, and we'll come on to that in a moment, but very briefly. I mean, a lot depends on who's actually responsible for running the system, and I'll talk about the business models for remote care towards the end of the lecture. But certainly you need to have clear responsibility for monitoring the data, for delivering the response, and for maintaining the equipment. And one of the problems, certainly in the UK and in other countries as well, is that it's very difficult to actually put in place those business models in a way that all the different parties involved in remote care. So from the equipment suppliers at one end through to the healthcare providers at the other end, so that all the responsibilities are clear and the payment and reimbursement across the chain operates in a way that's satisfactory to everybody. Okay, so we'll come back to that in a moment. Any more questions from anybody at this stage? Okay, well, I'll move on. And so that's a little bit about what we mean by remote care. And the next part really is all about the deployment of remote care and what progress has been made, specifically in the UK. And I mean, the UK is a very interesting example because, as I said, going back to the 1970s and 80s, we had this system of community alarms. So these are little pendants that elderly people were given. And if they fell over, an alert would be triggered and some kind of response would be made. And as long ago as 1980, something like 20% of all the world's population with this kind of technology was in the UK. So it was a very highly developed system going back 30 or 35 years. So we had this basic infrastructure from which to begin to think about creating a more sophisticated remote care system. And I'll just talk you through the history of that concept and how it was deployed in the UK. So there's nothing new about the concept. I mean, remote care actually goes back. Sorry, I've just gone back one slide. There's nothing new about the concept of remote care. That's an article from the Lancet in 1879, and the underlining has shifted a bit in the slide, but basically what it's telling you is that somebody phoned up her doctor in the middle of the night in 1879, and because her child was sick with a cough, and the doctor said, put the telephone receiver to the child's chest, and the doctor listened to it and said, well, I can tell you it's not croup, a particular condition. So that's perhaps one of the earliest examples of telehealth, telecare, going back as long ago as 1879. So there's nothing new about the concept. And in the UK, as I say, there are lots of positive things. First of all, there was a strong evidence base for the impact of remote care. And this is from a review we did nearly 10 years ago now. But we found there were nearly 9,000 published papers on monitoring patients, individuals in their own homes using some form of telehealth system. And around half of those studies were reporting on diabetes and heart disease. So there's a strong evidence base, certainly for the clinical and quality of life impact of telehealth. The economic evidence was much more limited, but again, I'll come on to that in a moment. So 10 years ago then, just cast your mind back, so 10 years ago in the UK, there was a review of the evidence. It showed there's good evidence for the clinical and quality of life benefits for telehealth, certainly targeted at some diseases. We had this basic infrastructure of community alarms. At the time, going back to the early 2000s, late 1990s, the government increasingly saw the home and the community as an important part of the healthcare system. The argument was that we've invested a lot of money in successive generations of hospital infrastructure. Hospitals are very expensive to maintain and run. Nursing homes for elderly people cost a lot of money. We're spending, hundreds of euros per week, hundreds of pounds per week, keeping somebody in a nursing home if they're elderly, hundreds of euros per night if they're in a bed in a hospital. And actually, given the emerging technology, given the evidence base, given the fact we have a basic community alarms infrastructure, we ought to be making more efforts to try and provide care for more people out in the community, in their own homes. So, so the home is seen as part of the next generation of telehealth, of healthcare. I've just seen a question come in about remote care dealing with subclinical cases. And I hope I've explained that. It's not just about people who have acute clinical conditions. It's also about, particularly about elderly people, people who have perhaps a set of comorbidities, but they're sort of fairly low level. They may be at risk of falling. So it's not just about acute clinical cases. I hope that's answered your question. So remote care is very much seen in the UK as part of the next generation of healthcare infrastructure. From the late 1990s onwards, there was a lot of political support for healthcare outside the home, and a lot of those reports have called for the introduction of remote care technologies. Many reports have called for it. There was public finance put in over a period of about 3 years, a couple of £100 million to pump prime and support telehealth and telecare projects. There's a big scheme called DALAS, which stands for Delivering Assisted Living at Scale. And around 150,000 people were going to receive remote care in about 5 or 6 different locations. And then there's something called the 3 Million Lives Initiative, which I'll come back to later on in the lecture. So lots of political support. There was money available. There've been many trials of remote care projects, and that's just one district, one county outside, just on the fringes of London, kind of suburban fringes of London. Those are just a few remote care trials deployed in a 7-year period in that particular county. The industry was beginning to get itself together, and the world's largest company making remote care products, Tunstall, is an English company, and it was very active at that time, trying to get its technology taken up and producing case study reports saying, if you deploy our sensors in people's homes, we can save you, so many days, typically, of beds in a hospital. So lots of industry case reports. And then one other last thing, remote care is beginning to enter the public awareness. So there were reports in consumer magazines like this one in the slide here about the technology, reviewing the technology and what it can do for you and which sensors are best. And even the Queen, so that's the Queen, and that's me with without a beard and more hair. And that's when the Queen opened our new building. So even the Queen got a lecture on remote care when she came and opened our building. So she knows about remote care as well. So there's the beginnings of a sort of movement to try and deploy remote care technologies in the UK. The question really is, given all that activity, given the evidence base, given the activity, how much remote care actually is there in the UK? And that's a very difficult question to ask. What we tried to do in our work for the whole system demonstrators program, and I'm going to talk about that in a second, is first of all to try and estimate the growth of numbers of people receiving remote care in England with various assumptions. And we reckoned in the early 2000s, there were very few people, there were perhaps about 15 people with remote care in the UK. And it kind of bumped along at a low level. There's lots of activity, lots of trials, but they tended not to be sustainable. So there'd be a pilot project, it would be tried out for a year or so, or 6 months, and then that project would stop. And it was about 10 years ago, in 2006, that the government started to get interested in remote care and started putting in money. I mentioned that £200 million. So it decided to put money into pump priming remote care projects. And it began to take off after that point. And around about 2010, we reckon that probably about 350,000 people with remote care, i.e. telehealth and more sophisticated telecare, i.e. not just a pendant alarm given to an elderly person at any given time receiving it. So if you know your literature on the adoption of innovations, and typically the adoption of innovations has a sort of S-shaped curve. So it starts very slowly, and then it starts to take off, and an innovation, more and more people start adopting that innovation, and then it begins to tail off. So you get a sort of S-shaped adoption curve. What we can see here is the beginnings of perhaps of an S-shaped adoption curve. Now, what we don't know is how far it has to go before it reaches saturation. Will it carry on increasing to, double that number, treble that number, 4 times that number, and then begin to tail off? And it's very difficult to answer that question. And what the next two slides shows is some sort of guess about the scale of the potential market for remote care. First of all, for older people. You can make some assumptions about how many older people are living at home, how many of them potentially need some sort of remote care monitoring at any given time. And probably in about 2010, that number, that 350,000 people who were receiving it, was maybe around about a quarter of the total potential number who could be getting it. And given the growth in an aging elderly population, that market might grow to 3 million in 2050. But those are just guesses. It all depends on the assumptions. That's telecare. That's aimed at elderly people and mitigating risk. For telehealth, so for people with whether they're subclinical or clinical people, but people with long-term chronic diseases, and we know that something like 20 million people in the UK have some sort of long-term chronic disease. The numbers could be huge. You know, perhaps 20,000 or so in the year 2010 had some sort of telehealth monitoring. Potentially, perhaps 450,000 or 500,000 could be benefiting from it, but we don't actually know. And really, it all depends on where you direct remote care. And the question that somebody asked about subclinical cases is very relevant to this. Are you focusing at it at the top 10% of those 20 million people with long-term conditions, the ones who really need careful management? You know, they've got chronic heart disease, chronic obstructive pulmonary disease, COPD, and they really need intensive management, case management, intensive monitoring. So there's people at the top of that triangle there. Or are the real benefits actually giving telehealth to people who are subclinical, who've just developed the early onset of diabetes or heart failure, and you give it to them at an early stage, and that means that you can monitor their condition more carefully and get their medication right. You know, tailor the medication much more to that individual's the progress of their condition. And of course, those numbers of people are much larger. So the point I'm really making is that because we don't know where the real benefits of telehealth lie, it's very difficult to say whether just to go back a slide, we just don't know what the scale of the potential market for telehealth is at any given time, but it could be huge. Okay, are you with me still? Any more questions? Okay, good. Well, let's just move on. So as I've said, the potential market for people who are elderly or people who have long-term chronic conditions could be huge. But there may be an even larger market for private remote care. And by that I mean people increasingly purchasing things like, you can see that, you know, wearables, Fitbits and other, you know, Apple iWatches and so on, where your health is being monitored. You're downloading your data to a website somewhere. Of course, the question is what happens to all that data? It's valuable to somebody. There are no real sort of business models for doing anything with that data yet. Of course, there are ethical issues and privacy issues about sharing that data. But already you can see signs that use is being made of the data from these. I can't see myself in the screen, so I'm hoping I'm waving my arm about, hoping you can see it. You know, there are signs that data is valuable. So, for example, in the UK, one of the private medical insurance companies gives you one of these devices and says, and they also own gymnasiums, sports centres. So they will keep an eye on your fitness data from your Fitbit, and they will say to you, you know, you haven't been walking much this week, you haven't been so active. Why don't you go down to the gym? You know, you have membership of the gym. Why don't you go down to the gym and be a bit more active. So you can see the beginnings of a sort of private market for remote care. Now, of course, in the UK, all healthcare is free. We have a national health service, and there is some private healthcare, but that's not something that many people have. But it's quite conceivable that that might grow in the future, along with these kinds of remote care, private remote care solutions. Another example might be where I might want to pay a certain amount every month, £20, £30, £50 a month, perhaps, for my elderly father who lives 200 kilometres away in a flat, in an apartment. For him to have a monitoring system, just so that I know that he is safe and secure in the home. One of the questions that's just been sent to me is, are there any tools encouraging the private sector to get involved in this? And the answer to that is, there are no direct tools. There are no incentives for the private sector to expand remote care. But although we have a free healthcare system in the UK, social care is not free. It depends on your income. So I don't know the percentage of people who have to pay fully for social care, but quite a large proportion of the population will have to at least pay something for their social care, and that's provided by private social care providers. And those social care providers receive some funding from the state as well. So there's a sort of hybrid market as well. And some of those social care providers will be adopting telecare or are adopting telecare systems. So there's a sort of mixed economy for social care. So in time, I think there will be a growing private market. So on to part 3 then. So that's the sort of general picture, the general evolution over the last 10 years in the UK. And I think it's fair to say that there's been a lot of activity, lots of interest. Government's been very supportive. It's provided some funding. There have been hundreds of pilot projects and trials, and there's certainly been some growth in the number of people with telehealth and telecare. But equally, there are a lot of blockages to the development of mainstream remote care. So that's what I'm going to talk about next. And people complain about these pilot projects. We talk about pilotitis. The joke that people make is that there are more pilot projects. Well, sorry, there are more pilots than there are pilots in British Airways. We love creating pilot projects which last for a few months, and then they're not sustained. They don't scale up. And I see somebody's asked about the Philippines. And one of the big problems in global health is lots and lots of pilot projects in global health projects in global health, run by NGOs, and they fail to get mainstreamed. They fail to scale up, and equally we see that within the UK as well with telehealth. But on the other hand, all those pilot projects and the whole system demonstrators, which I'll come on to, have nevertheless told us a lot about the organisational and economic barriers to adopting remote care. They've been very useful because they've given us a really good insight into what we need to do organisationally and what we need to do in terms of finance and support to scale up remote care projects. If you look at the evolution of a remote care project locally, so this is for a specific locality, a healthcare organisation or a local health system, a local city, for example, typically what you find is that there's this early period of adoption, and some enthusiasts locally, doctors, nurses, social care professionals, might find out about telehealth. They've read about it in medical journals or the news, heard about it on the news. Perhaps they've got a little bit of money sloshing around from grants, and they try things out. They adopt it. They make a decision to adopt it, and we'll try it out. We'll do a little pilot project, and things are happening at a very low level, and they're just experimenting. And then typically they might get some pump priming support, maybe locally from their local healthcare organisation that they're working for, and that allows them to spread the idea or to begin to scale it up. But what you find then is that you need to start. It all starts to get a bit more complex because you need to start engaging different bits of the local health and social care system. Initially, it may have started just within the acute hospital or the primary care sector, but you find that you need to engage with more people from different healthcare organisations. So perhaps you need to, if it started in the primary care sector with general practitioners, you then need to start talking to doctors in the hospital, because an individual's care, is usually spread across different parts of the healthcare system. So you need to start engaging across the local healthcare economy. You need champions who can sell it to other organizations, champions who can bridge boundaries in the local care system. So somebody who can knock heads together, get different bits of acute and primary and social care system together. As projects get bigger, you need project management, you need leadership to sell it locally and lead the projects. So it all needs to become more formal, and you need to engage with more people. And that's when you find these projects start to run into difficulties. They find it very hard to engage across organizational boundaries in the system. And you can have champions in place, trying to sell it, but certainly within the UK healthcare system, and this is typical all over the world, you find it's actually very fragmented. So even though in the UK we have a national health service, it's paid for under taxes, it's effectively free to everybody. It is actually very fragmented. So hospitals are one type of organization. General practitioners are all private, although they're paid by the state. But they're individual, they're grouped into local general practitioner groupings. Social care is provided locally by local municipalities. You have tertiary hospitals, so it is a very, very fragmented system. And bringing together those different organizational and financial silos is always a huge problem when you're trying to do something different. All those organizations, hospitals, general practitioners, social services, are all financially independent, even though they're paid for out of the state system. So you get problems of costs and benefits of an intervention, if you start to bring something in, the costs and benefits don't necessarily fall equally across the healthcare and social care system. So you need to align the incentives. And so this bit in the middle here, this spread bit, diffusion bit, is really, really difficult when it comes to a complex innovation like telecare, like telehealth. And then if you really want to mainstream it, you reach a point where you have to start gathering evidence. You have to evaluate what you're doing. You have to evaluate the projects that you've put in place. Gather clinical evidence. Gather evidence on the economic impact of those pilot projects, and then create some kind of business case. And evidence is, as we know in healthcare, is critically important. Doctors often don't want to change or bring in a new drug, bring in a new technology, if the evidence base is perceived to be weak or the evidence is unclear. And again, I'll talk about this a little later on in more detail. But if you haven't got good quality evidence, it's very, very difficult to bridge the boundaries across different bits of the healthcare system. And what we found when we were doing our work on telehealth, looking at the organisational barriers to adoption, we found that some parts of the healthcare system would accept the evidence and other parts wouldn't. So if you're a clinician in a hospital, you might only believe studies that involve a randomized controlled trial of the technology, whereas general practitioners or social services people or nurses had a different view about what constituted good evidence, and they were much more interested in the quality of life and the stories told by patients, for example. But unless you can get good quality evidence, clinical and economic evidence, then it becomes very difficult to scale up or to create a business case that will convince managers and finance directors in hospitals or in primary care organizations that they need to invest in telecare. Okay, still with me? So round about the, 8-9 years ago in the UK, we'd reached this point then where there was lots and lots of activity, lots of pilot projects. We knew a lot about the organizational barriers to adoption. But what was really weak was the quality of evidence. We didn't really know what worked and in what circumstances it worked. Which kind of patients, at what point do you give them telehealth? And we didn't know anything about the economic evidence. And that's despite the fact that there were, as I said a little earlier on, there are 8,000 or 9,000 published studies on telehealth and telecare. And that was really felt to be a major factor hindering growth of the market. And that leads me on to the whole system demonstrators, really, where the government said, okay, we've done a lot. We've tried things out. We know a lot about what telehealth and telecare can do. There's been lots of trials, but we don't really have the high quality evidence. So what we're going to do is to set up the largest randomized controlled trial of remote care ever undertaken anywhere in the world. Huge project with something like 6,000 people, 6,000 individuals, 3,000 in a control group and 3,000 in an intervention group. And do that in 3 different locations. And we will evaluate it and we'll look at not just the economic evidence or the clinical evidence, but we'll look at quality of life. We'll look at the technology, the interoperability. Somebody just asked a question about interoperability. We'll look at the technical issues, the quality of life issues, the impact on healthcare professionals, how it's changing their jobs, as well as the clinical benefits and cost effectiveness. So we were part of that trial, and it was a very, very difficult, hugely challenging project to put in place. It took much longer than we thought. It cost, I don't know how much, but £2 or £3 million to do the whole thing. Huge amount of money. And despite the fact that it delivered a lot of very interesting data, and there are a lot of peer-reviewed findings from the Whole System Demonstrators program, and some of those are in the reading list that I gave you. And perhaps we'll talk about developing countries later on. I can see the conversation in the chat. You know, doing it in the UK is one thing, doing it in Iran is another. So despite the fact that the trial and the study developed, created a lot of information, it's still very ambiguous. But nevertheless, what the government said was, well, it's all looking pretty good. It seems to be leading to reduced emergency department visits, reductions in elective care, so that's scheduled care as opposed to unscheduled care. It seems to be reducing the number of days people spend in hospital, so 14% reduction is pretty good, and it's reducing the costs. So great, let's roll this out to 3 million people, and we'll do it really at scale. And the Prime Minister announced this and said we're going to put in place a program to do this. Unfortunately, actually, they were slightly premature, because all that data on emergency department visits, elective care, and reductions in bed days and so on actually was very, very ambiguous. And we don't have time to go into the data in great detail, but I can just show you some of the key findings relating to emergency admissions. So if you remember, the government said 15% reduction in emergency department visits. So it sounds pretty good. Well, actually was the picture. And what these graphs show from one of the papers is the data actually on what happened before and after the introduction of telehealth and telecare. And the line, the solid line on the graph is before, so to the left of it is before the Whole System Demonstrators program was put in place. And then to the right of the line is what happened after. And then you've got the control group and the intervention group. So so in each of the three localities, it's comparing the people who received telehealth with those who didn't get it. And what you can see is that before the introduction of the Whole System Demonstrators, there was a sort of general increase up to a sort of plateau of people in the top left here, people receiving emergency admissions. And then the trial was put in place. And then it's all a bit ambiguous, actually. And actually, the number of people actually went up receiving emergency admissions and visits to accident and emergency. And that's pretty strange. Now, I'll explain that in a moment. So far from there being a 15% reduction, it actually went up. Things then stabilized after a while. And the same goes for telecare. So that's directed at elderly people specifically, rather than people with diabetes and heart failure and lung disease, which is the previous slide. Again, the introduction of telecare seems to have actually initially led to an increase in emergency department visits and an increase in falls as well. So it's actually pretty difficult to interpret that data. And what seems to be happening is that actually, because you're monitoring people more intensively, you're actually picking up more conditions. So you're monitoring people more intensively. You can see problems developing, and you're simply increasing the volume of healthcare because you're detecting more problems, and that's actually typical of many healthcare innovations. If you bring in a new technology in healthcare, it allows you to do more things. You can detect more problems, and you have to intervene more. And that's generally been the experience in developed countries' health systems over the last 40 years. The more technology is introduced, the more it drives up demand on the healthcare system. The other thing to say is that the WSD trial was very short term, and we were only able to monitor the impact over a fairly short time after introduction of telehealth and telecare. So it probably would have taken longer to bed down those problems and the true impact to become obvious. And the other thing to say is that there are very, very complex cost-benefit issues. Even though it said there was something like a 15, I forget the figure, 8% saving on the healthcare costs in those sites, actually it probably wasn't as much as that, because you have to consider the cost of setting up the technology, which would have been high, and was included in the costs of that scheme. And you have to consider the distribution costs across the care system. So you may be just shifting cost from the hospital into the primary care or social care sector. So the economics are difficult, and the clinical benefits and impact on bed days and emergency admissions are difficult to interpret as well. So WSD was a huge trial, cost a lot of money, but it never really delivered the quality of evidence that was anticipated. And one thing we've done subsequently is to take some of that data and do some more sophisticated modeling to look at the impact over time across the national health system. And that's just, I don't expect you to read that slide. It just illustrates a system dynamics model on the top right there, and some of the outcomes of running that model. But it's looking at the impact of telehealth for heart failure patients at a national level, and what might happen if you bring telehealth in to monitor people at different stages of their disease. So at a very, very early stage, when they've first been diagnosed with the problem, and then at the later stages of the disease. And the blue line, and what the graph shows at the bottom is over a period of 100 months. The blue line shows the number of the estimated increasing demand on hospital beds over that period of time. So it basically shows that there'll be a steady increase in demand if we don't do anything. If we don't intervene, you'll get a steady increase in the number of days spent annually in hospital over time, caused by people with chronic heart disease. And then the other lines, all the other lines, are what might happen if we introduce telehealth to monitor people, depending on our assumptions about where we intervene. And basically what it shows is that it will take some of that demand out of the system. So over time, you're slowing the increase in demand on the hospital system caused by the increasing number of people with heart failure. So the point I'm simply making is that a lot depends on the assumptions you make, but you can, from what we know about the impact of telehealth for particular conditions, and in this case here in this slide, heart failure, we can look at what the impact might be on the health system at different levels. I mean, you could do the same thing for a local health system in a city, for example. So we need to be more sophisticated about how we model the impact of the trials that are carried out. Still with me, everybody? Okay. The other interesting thing to say, but before I move on, is that the Health System Demonstrators Program, the WSD, is a very interesting case of evidence-based policy making, and this certainly applies to developed countries' health systems or political systems even, where in the UK and elsewhere, there's lots of emphasis on trying out policies in pilot projects before they're then adopted. I mean, sometimes the government will just say, well, we're going to do this, and they just go and do it. We've got problems in the UK at the moment with the government trying to change part of our healthcare system without any real evidence, but they're sort of ideologically driven, and they just want to change things. And we've got a doctor's strike today at the moment in the UK because of this. But the whole system demonstrators was an interesting case because the government explicitly said we're not going to roll out telehealth and telecare on a mainstream national basis until we've done the WSD and we've got the evidence. And then before the evidence was fully published, and they said we want the evidence to be peer reviewed in journals, fine. But then they got tired of waiting for it because, of course, it takes time to do sophisticated economic and clinical research, and they got bored with waiting for it. So the Prime Minister said, we've got some headline findings, some interesting findings. We'll just make a policy now. So those early findings about bed days saved in hospital and emergency admissions and so on was translated into money. In that newspaper article there, it said we're going to save £750 million a year by introducing remote care, and we're now going to roll it out. So it just provides an interesting case, if you're interested, of policy making, health policy making, and how it can go wrong. Okay, so that's the whole system demonstrators program. Where do we go from here? So things have sort of stagnated a bit in the UK since then. Having been one of the countries in the world which was leading the way, things have probably stagnated, and other countries are doing more interesting things, I think, than we are. You see the same old arguments coming up time and time again in the UK about who's going to pay for it, who's responsible, who's in charge of integrating the technology, who's in charge of the monitoring the data, and so on. So where do we go from here then? What do we do to move forwards? I mean, the first question I think is this point about evidence. I mean, I said that evidence is really important, and it clearly still is. If you're going to introduce a new healthcare technology or a new drug, often there's a lot of rigorous testing. There's the whole health technology assessment process to explore and evaluate the impact of that technology. And certainly for drugs, when there's a risk attached, you go through a formalized process of testing that drug in different ways before you make a decision about whether to adopt it or not. And that's fine. I certainly don't want to be given new drugs that haven't been carefully tested on people. But we also know that even when there is evidence, things still don't get taken up. And this is not just specific to the UK, but you certainly find that in Britain, but also in other countries. There can be all the evidence in the world. There can be 8,000, 9,000 peer-reviewed journals, 40% of which say it's a really good idea, and 20% say it's pretty good, but you still don't get an innovation being adopted. So evidence is important, but it's necessary, but it's not sufficient to scale up new innovations. And here's a quote from one of the technology suppliers we interviewed. Technology suppliers, whether it's specialist companies making sensors monitoring people's vital signs, or whether it's Philips or Siemens or you know, one of the big global healthcare technology companies, they all say it all boils down to doctors. Clinicians will look at the evidence, and you can show them the evidence, and they will still not adopt it. And there's a whole host of reasons for that. There's a sort of not invented here syndrome applying. So people often say, well, that's fine, okay, you know, there may well be evidence, but it's gathered in some other healthcare system somewhere else, you know, another organization, another part of the UK, another country, and we're different. It's not applicable here in my hospital. So we're going to do our own trial. We'll do a pilot project. We'll do a trial. Then we'll make a decision. So you, consequently, as I said, you get the same technology, the same solution being tried again and again and again. So they'll think it's a good idea, but you know, not necessarily that you should adopt it. And that's very, very common. And I'm doing a piece of work in Italy at the moment, in fact, looking at dialysis in the home. And we're doing interviews in Italian hospitals about home dialysis, home kidney care. And you get the same things happening. You know, doctors will say, no, you know, we don't do home dialysis. We don't believe the evidence, or you know, well, we're going to try out a pilot project, and you know, it doesn't matter if the neighbouring hospital has done it. We want to do it ourselves. And one of the problems is explained by this slide here, really. And as I said right at the beginning, telehealth, telecare, remote care is an immensely complex technology innovation. It involves some technology, you know, physical technology, sensors, information technology, some sort of home hub, but it also involves a lot more organizational change. It's about new service delivery models being introduced into a healthcare system and a social care system. So you need to reorganize how you deliver that aspect of healthcare, whether it's care for elderly people or care for people with chronic lung disease or heart disease. You're inevitably changing the way health and social care services are delivered. And you've got to engage with different organizations, primary, secondary, social care. It's highly operationally complex, lots of stakeholders involved. The economics are very perverse, so you might find that the number of days spent in hospitals, beds, for people with heart failure are, you know, you might reduce that. So the hospital is, well, I mean, it wants to keep the beds full, of course, because it gets paid for those, but you know, it may just fill up those beds with expensive, you know, different types of patients. But equally, you might be shifting cost from the hospital to general practitioners and the primary care sector. We're having to care for people in their own homes for longer. So the economics are not clear. And the other point is that the technology is not stable. It's evolving all the time. New sensors are being developed. The price is coming down. We've got all these wearable devices, Fitbits, yeah, for example, being developed. You know, you don't need dedicated video conferencing. You can just do it through Skype or WebEx. So, you know, you're not evaluating a constant technology. Everything is changing all the time. It's changing the organizational systems and processes. The technology itself is changing, and the healthcare system is evolving as well. Governments come in, they introduce new policies. So it's very, very difficult to gather clear evidence for the benefits of remote care. Consequently, the evidence base might be large, but it's contested. Okay. Any questions? So that's the first point then that makes scaling up and mainstreaming difficult. The second point is that it's very, and as somebody mentioned this right at the beginning, you know, what's the business model? Who's responsible for what? Second point is that it's actually very hard for suppliers of different aspects of the telehealth supply chain to create a business model, and for providers of healthcare to create a business model. And what do I mean by that? I mean that if you want to create a business model, you need to understand basically who is offering what. You've got a supply chain of manufacturers, IT companies, telecoms companies, private and public healthcare providers from the acute and primary healthcare sectors, ambulance services, voluntary sector, home visiting organizations. All those different stakeholders potentially are involved in a telehealth or telecare business model. And how they're connected together, how they're glued together, and how value is generated and flows through that system is very, very unclear. I mean, it depends on what type of telehealth you're providing. Depends on who's responsible for it, it's hard to see where, you know, if you are the manufacturer of a technology, you know, one aspect of the technology, the sensors or providing IT applications, it's hard to see where you sit within that value chain, and it's hard to see how you make money or profit from it. And it doesn't matter whether you're in a purely private health system or whether you're sitting in the UK with a national healthcare service. Obviously, the NHS, National Health Service in Britain, as I say, it's you know, doctors are free. It's free for me, but there's still a private sector supply chain within that system delivering the drugs and technologies. So the business models for remote care are pretty hard to pin down. And that's always been a difficulty in establishing mainstream remote care services. I can just see some comments coming in on the chat. Just give you a second to read that. Yes, I mean, it has to be government driven, I think. You know, a purely private solution is, I mean, in most countries, you know, a large part of healthcare is shaped by government policy and, you know, some sort of insurance-based system. I mean, out-of-pocket payments vary from country to country, so they might be high in the Philippines. I imagine they're you know, they're probably fairly high in the Philippines, but nevertheless, you know, there are health policies, there are the government does shape the system. So I think a lot of this does have to be driven, at least from the top, by governments putting in place the incentives and targets, perhaps, to you know, which suppliers then go and develop the telehealth solutions around that. So business models are difficult. Third point, we need new kinds of partnership between different parts of the supply chain. And I'm going to talk about public-private partnerships in September, I think, when I come back and do another lecture on this course. So I won't say very much about that now. But simply to say there's lots of discussion about public-private partnerships in healthcare and in the UK, and new ways of engaging the private sector within public sector healthcare provision. And really that's all about bringing together suppliers of technology and services and physical infrastructure, built infrastructure as well, in new ways, where you've got health services, the technology, the infrastructure, all within some sort of public-private partnership arrangement, where everybody is sharing risk, sharing the costs and benefits. And that's certainly been shown to be one way of incentivizing innovation, innovative behavior, because the cost and benefits fall within the public-private partnership. They're not distributed unevenly across organizational boundaries. So I certainly think that to get telehealth going, you need to think very carefully about how the public sector and the private sector needs to engage in new kinds of partnering type relationship. But I'll talk about that in the next lecture. Finally, money is important, and who pays for what is important. And there's often an innovation penalty you find in healthcare systems. It costs money to be innovative, to bring in some new idea. And we see that very frequently for all kinds of innovation, whether it's an organizational innovation or adoption of a new technology. The adopter is paying for it. They've got costs of implementation. They've got to think about not only procuring the technology, but redesigning services. They may have to go through some kind of organizational change and management exercise. It may be some time before the innovation benefits are seen, and we saw from those graphs of the whole system demonstrators outcomes. There was a lot of sort of wobble around the data around the time the technology was introduced, and you actually saw the impact on the health system increasing initially. So one of the things that's been done in the UK is to reward hospitals and healthcare providers that have been innovative and increase the payment that they receive from the Department of Health if they're incurring increased costs in the short run because they're doing something innovative, including introducing telehealth. And that's had some effect on incentivizing healthcare organizations to be more innovative and to adopt new innovations. So I think you can, just to go back to that last point in the chat, you know, somebody said it has to come from the top. I think, you know, government has the power to shape what happens on the ground. It has the power to bring in policies that incentivize innovative behavior. And that's certainly one thing that we're trying to do in the UK now. So those are 4 different areas that need to be tackled, I think, to mainstream telehealth. So just finally, before I finish the lecture, I mean, we all, you know, go back in time, and I said that, you know, there's a very early report of telemedicine or telehealth in 1879 in the Lancet, and there's another example in 1924, the radio doctor. So, you know, an example of early thinking about telemedicine or telehealth. But the point is, we always seem to be at some sort of tipping point. Commentators from the industry and you know, experts always are saying, well, you know, we've reached a tipping point. It's going to take off now, and it never quite seems to do that. And those quotes in the slide are just examples from industry specialists going back 16 years now, saying you know, just give it a year or two, and it will be mainstream. And it never quite seems to happen. And that one down the bottom eHealth Insider, 2008, the year telehealth grows up. Well, you could probably come back 8 years later and say the same thing. Is 2016 the year it finally grows up? But I do think that since we did our studies on the WSD, things have moved on. And we had a little bit of a discussion right at the beginning about consumer products and private markets. And as I said, there's a sort of escalation in consumer-focused health technology now. Smartphones all have health apps on them. My Samsung smartphone can measure my heart rate, can measure my saturated oxygen level, measure my sleep pattern, measure my movement. I've got a Fitbit. I don't have an iWatch, an Apple Watch. But there's more and more of this technology being used. And I think it's just getting people more used to monitoring their health, more used to thinking about data, and that data is all potentially monetizable. It can be monetized. So you do have Fitbit and Apple and Google all trying to think about what they can do with it. So I think we are beginning to reach a point where the concept of telehealth is becoming more widely accepted and mainstream. And you'll get pockets of remote monitoring being adopted, I think. People will just pay for private solutions, if they've got the money. So I might just pay Apple or Google to, for a more sophisticated monitoring of my health than I get from my Fitbit at the moment, for example. So we're beginning. Wearables are all the rage at the moment in the industry, and it's certainly becoming maybe we're reaching a tipping point because of that. There's another reason, I think, which I don't have a slide for, but if you just remember the very first slide I showed, I think, was about a smart home, saying, the home is going to be, all the functions of the home are going to be integrated. Well, now there's a lot of talk about the Internet of Things. All these devices are being Internet enabled. So the concept of the smart home is now reaching a point where there's lots and lots of interest in Internet enabled technologies within the home itself. So the question really is, are we at another tipping point, or will we be coming back in 5 years' time saying, we're at a tipping point still? Who knows? I don't have an answer to that. So there we are. That's a very quick lecture on a lot of complex issues. But I think the takeaways that I would say are, there's no shortage of technology. The technology isn't the problem. The devices have been developed. They're getting more sophisticated. They're not expensive. You have a lot of companies, from the large-scale global players like Philips and Siemens and Google and Apple, right through to specialists just producing one particular app or one particular monitoring device. And the technology is not the issue. It's entirely to do with the organizational and business models. And of course, they have to be specific to a national health system, which would be different in the Philippines, different in Iran, different in the US, different in France. And they have to be specific to that local context. And it's about evidence and the ability to collect good quality evidence, which can be then used to convince investors, whether they come from the private sector, that remote care is a good idea worth investing in, or whether they are the manager or the finance director in your local hospital that he or she should be investing in that particular innovation. So I'm going to stop there. Thanks for listening. It's a little hard doing a lecture when I can't see everybody, but I hope that was reasonably clear. I've given you some reading. There's more reading on the list than you want to read, but I've highlighted some of the key things. So what do we want to do now? Do we want to have a bit of a conversation online, or do we stop there? I guess I should ask. Are there any more questions for me, or observations or thoughts? What range of countries do people come from who are listening to this at the moment? I've got the Philippines and Iran, I think. Sudan, okay. I've been to the Sudan. I went there about 30 years ago. Where else? I haven't been to Iran. I haven't been to the Philippines.
Oh, you can come here anytime.
We're end of time, are we? Okay.
Nigeria.
Nigeria. Okay, good. Well, thanks everybody for listening. You've got my email there. If you've got any questions, please don't hesitate to send me an email. I've given you some questions, a sort of multiple choice set of questions which are based on the slides. So please do those. You can follow me if you want to follow my tweets as well. You can see my Twitter name there. Okay, and it's good weather in England as well at the moment, but cold. Thanks everybody. I'm going to sign off now.